This is Dr. David Pomeroy, your host on ADHD Focus. I wanted to remind you that the show is not intended to be a recommendation for diagnosis or treatment of any condition for any specific person. Please consult your mental health professional or doctor managing your ADHD or mental health issues about any diagnosis or treatment-related information that you hear on the show. Refer your ADHD provider to the show if he or she would like more information. Thank you.
So glad you could join us today. My guest is Elaine Taylor-Klaus, founder of Impact Parents, a master certified coach. She coaches parents and professionals in dealing with the complexities of ADD, Asperger's, autism, depression, anxiety, all those things that go on with ADHD. And today we'll be talking about girls and autism, ADHD, the combination, particularly the problem of late diagnosis and misdiagnosis, which is something all of us in the field are struggling to understand and figure out. So Elaine, welcome to the program. Glad to have you back.
Thank you. It is always a pleasure to spend time thinking and learning with you.
I appreciate that. So how did the topic or the encounters you had lead you to looking at, gee, we're missing something here?
I think it's because I had so many clients who we kept saying there's something missing here. Personally, I was a parent of several complex kids, but one particularly complex where I found myself saying, yeah, but we're still missing something, yeah, but I know there's ADHD and anxiety. I know there's learning disabilities. There's something missing. And then in the last couple of years, I began to notice a similar pattern with my clients. And I often say that I work with our company, Impact Parents works with parents of complex kids. I tend to end up working with a lot of parents of very complex kids, right? They're really more complicated, where there's kind of something missing. Those are the people who often end up on my Zoom screen. And I had the fortune of being invited by Dr. Thomas Brown to join him as a panel presentation at AppStart a couple of years ago. And he asked me to do some case studies. And so that called me to come back and look at my doc of clients over the last several years. And I began to see patterns, and I began to notice similarities. And notice how many clients I had who were very complex kids, where it turned out that it was a pattern of kids, mostly girls, mostly teenage girls, whose diagnosis that they were being treated for primarily wasn't really addressing enough of the need. And when I started looking into it, I began to notice all of these things these kids had in common. And, the spoiler alert is that I began to start sending my clients back for reevaluation because I saw the commonalities. And because when, from my lens, I know what a complex kid with ADHD and learning disabilities or anxiety, whatever, looks like. And when you have a parent whose kid is an outlier in that space, it was a real clear opportunity to say, let's go back and look and see if there's something else. And one by one, all of these teenage girls were then now under the current diagnostic criteria diagnosed with what some people would call high functioning autism. I like the term Asperger's, but we're diagnosed with autism in retrospect now in a way that they couldn't have been diagnosed before.
Right. Now, what were the problems or what was showing up that still wasn't getting addressed, was still too much of a challenge, even though the treatment seemed to be optimized for what it Okay, that's what we're going to do for ADD and all those things. Well,
maybe they were treated for ADD, maybe they were treated for OCD, but there was, they were being treated, actively treated. But what I began to see as some of the common threads were there was often extreme attachment to one parent, sometimes at the resistance of another parent. But I'd have to go back and think. It was usually not an extreme attachment to both parents. It was usually one parent where there was kind of a push me, pull you. There was I hate you, I need you intensity. It was bigger. That old book, I hate you, will you drive me to the mall? It wasn't that casual teenage thing. It was much more intense. So there was an extreme attachment to one parent, to the point where that parent didn't feel like they could go out, they couldn't leave, they could barely go to work. There was just this almost obsessive need for the parent to be there. And in hindsight, on some level, they were using the parent to co-regulate to an extreme extent.
Okay.
Sometimes there was a resistance to the other parent, but not always. But sometimes there was a very, he's dead to me, I need you, Mom. That was going on. The other thing I noticed that was happening a lot was that there was always some kind of a sleep thing going on, where oftentimes parents weren't sleeping in their own beds, or kids were sleeping on the floor next to their parents, or parents were being called upon to sleep in the kids' room, or there was some interruption of what you would consider typical sleeping patterns. And that was much more common in these families than I saw in the other complex families that I was supporting, where these issues weren't at play. What else? As I said, early treatment had started at a very early age for all of these kids, but it typically focused on one diagnosis or a clump of diagnoses to the exclusion of others.
So early age in elementary school?
No, preschool, early, treatment may have started as early as 3, 4, or 5 years old. And I know in my own circumstance, my child's first psych ed evaluation was done. They were about 5 years old. Because by that point, we had already been to several preschools. Like it was hard by 2. And so we were finally getting an evaluation by about 5. But that was common in all of these families, is that these issues didn't start showing up at 7 or 8 years old. They started showing up much, much earlier. And sometimes there were conflicting diagnoses. So multiple providers with, one saying this kid's got ADD and one saying this kid's got autism and one saying this kid's, attachment disorder. And so conflicting diagnoses, which left the parents with a lack of clarity about what are we really treating here? What are we really trying to help and support? So that was pretty common. There was a common theme of what I would call emotionally eruptive behaviors, extremely emotionally dependent, but also volatile. In the autism realm, they call it mood storms. But it was less typical to see that in girls than in boys. Like in boys, you would see that and might question whether that's on the autism spectrum. But because it shows up a little differently in girls are maybe less likely to tear up a room, but more likely to become really eruptive and then to beat themselves up, to turn that eruption on themselves. I don't deserve to live. I don't deserve to be here. Becoming really almost self-blaming in the wake of an eruption. But this emotionally, there's meltdown and then there's eruption. And it's one thing to be emotionally dysregulated, as a lot of kids with ADHD are. But there's something else to be eruptive, where there's just these kind of explosions that these kids can't control. And then the unifying theme, and this is consistent with all kids with autism, not just girls, is sensory issues. A lot of sensory issues from an early age, different kinds of dysregulation, but often a reactivity, whether it's to sound or sight or light or people.
That's true. Mm-hmm.
All kinds of sensory kinds of things. And then there's the subtle thing. You and I were talking about subtleties earlier before we started this recording. The subtle piece that I noticed is a lot of these kids, I began to call them wanderers. Because when the kids would get saturated, they would leave. They would walk out of a classroom. They would walk away from camp. And I had several kids who would literally walk all the way home. And they weren't running away. They were actually leaving and going home because they were done. They were saturated.
Yeah, overwhelmed with stimulation and everything else.
But they wouldn't stop to say to a teacher, I need help, or I've got to get out of here, or I need a quiet room, or what. Now we have things like quiet spaces, and we have ways to help kids in school environments. But not that many years ago, these kids would just literally walk out of a classroom and down the hall and out the door. Or they would get into lots of fights or combative kinds of situations. But more likely, they were, as I say, I call them the wanderers, and I began to see this theme. And then the last thing I would say, I guess two more things. One is these kids very often wanted social connection, but it was extremely difficult for them. They did want it, but they just didn't know how to be in social dynamics. I remember this one girl who it was every week when I was talking to the parents, it was always about Girl Scouts and the complications and difficulties of trying to help this kid be in Girl Scouts. Inevitably, the parent is the Girl Scout leader because these parents are often taking leadership roles so that their kids can be in social settings.
Right, so they can be present there. Right.
So they're either coaching the team or they're Girl Scout leader or whatever. Because the kids do want a social connection. They just don't know how. And then there's also often a history of the kid being bullied. But I think there's a lot that we could say about it, because these kids, sometimes they're the bullies and sometimes they're getting bullied. But very often that's an extension of that social disconnection piece.
Yeah, can't defend yourself or don't know how to deal with something that makes you feel uncomfortable, so get aggressive or whatever.
Or you may feel like you're being bullied, and it's because you're not reading the social cues and you don't really realize. So there are a lot of pieces that play into that. But these are all. I began to see this in this whole group of clients to such an extent that I actually picked up the phone and called a client from about 10 years ago, because I was so remembering her child who was like all these other girls. And I called her and I found her and we got on the phone, and the kid was now 22, 23 years old. And I said, tell me about where she is. And she had finally gotten an autism diagnosis. And it was absolutely consistent. And now the college version of that. Very often playing more with boys than with girls, because I think boys are socially less demanding than girls. So she had, by college, had gotten into she was one of the guys. But sometimes there's also some sexual acting out that happens later, that it's different kind of sensory seeking. I'm not as familiar with that. If I stay focused on these girls that I'm really speaking to, there were all these consistencies. Almost all of them ended up in either treatment programs, hospitalization for a time, some kind of a therapeutic environment.
Extreme. Yeah.
Because by the time they figured out the autism, it was as a result of being hospitalized.
A bunch of, right. I wanted to return to one thing and looking at things that I have, the sensory issues, which in everything I'd seen up in certainly from 18 years ago when I started in this practice, sensory issues were often considered to be part of ADHD. And I think that may be something that, I don't know if it's a variation of ADHD, but maybe that was a clue that we weren't picking up, that there is something else, and maybe the sensory issues, partly that, but really some elements of the sensitivity. And I think of certainly a lot of people, I think, with ADHD are very sensitive to noise and sound. I don't think anyone with ADD can ignore a single conversation that's happening nearby. If there are multiple ones, fine. But a single one, there's that ear is listening, kind of. So it's hard to process two conversations at once. But
So can I speak to that? Because you just said something that's really interesting. There's sensory in terms of overwhelm, which I think you see a lot in ASD. There's sensory in terms of distractibility that I think you see more in ADHD. Mm-hmm. I agree. I think a lot of kids with ADHD do have sensory issues. But the manifestation of it is different. With ADHD, I may have a hard time with that line in my socks because I can't think about anything else because the lines in the sock is bothering me, which is very different from I can't be with wearing socks. Or I can't stand that you're eating so loudly. I can't be with it. Is different from I can't hear what's happening over here because I'm distracted by the sound.
Yeah. And
same behavior, different reason for it.
Right. And I think that the overwhelm is the part that's different. I think of, I look at, there's this sensitivity to if it's texture of clothes or sometimes textures of food. And then I tell parents and the teenager, whoever, that your emotions are also sensitive too, but you don't necessarily identify that. A 9-year-old is going to identify that very easily, but that's where you're seeing it in the overwhelm, in the meltdowns, the mood explosions. And I think with the autism part, that's where it's a more significant overwhelm, too much sensory stimulation. I don't want to go to the mall because there's way too much going on.
And I think what we don't give enough credit to when you look at executive function is the role of energy management. So, and whether it's, and whether ASD and ADHD are completely separate or whether they're just a continuation of the spectrum is a whole other debate, which I don't want to go into. But there is something about the executive function impact of regulating your energy, of managing your energy. And we see it a lot in the ADHD space, people whose energy comes and goes, and sometimes if they need something to stay engaged and otherwise their head's on the table. But the same is true similarly for people with ASD, that it takes a lot of energy to be around a lot of people or to be in a space. I mean, my kids will say to me, peopling, Mom, peopling. Peopling's hard. It's exhausting. And it's one thing to navigate it if you're neurotypical or if you have kind of your, for lack of the better word, run-of-the-mill ADHD. But I think when that moves into this space of autism, it takes longer to refill your cup. It drains your cup quickly, and it takes longer to refill it.
It takes longer to.
There's a concept about spoons. Do you know about the spoon theory?
Yeah, you run out of spoons faster.
You run out of spoons faster. You have a finite number of spoons, and once they're gone, you got to replenish.
And maybe that speaks to some of the I've got to be alone time, and whether it's I'm going to go read, I'm going to go escape into my room. Unfortunately, I think now I've got to escape onto
the screen,
my phone, the screen, the games, and then get into the whole social media thing, which is another big tangle of people and emotions and overwhelm.
Yeah. Well, and it's also a way that I think makes socializing easier for people on the spectrum, right? If I can do it through the technology, it takes away a whole energetic drain and allows me to be social without, I
don't have to read cues and people and get distracted by color of their shirt or whatever.
Exactly.
Does it, and I'm thinking to some of the boys and men I've seen with kind of, it might be said, some of them were the typical autism high interest in one thing, but then it shifts. I was 10, I think. Mom said, 2 months ago, I couldn't walk down the aisle that had candles in it because he didn't want to light them. He just wanted the candles. And now it's Rubik's Cube. And I don't think he stopped playing with a Rubik's Cube the whole time we were talking. And, he'd mix it up and I'd say, okay, let's see. And, in a less than a minute, he'd have it solved.
I had those.
And I gave up very quickly on those. But that high intensity now, what I've seen in someone who was a programmer in his mid-20s, he could figure out networks and a different way, a more efficient way to have a networks communicate. And the level of detail was way beyond what even his coworkers could understand. And what showed up to him is, his manager would say, how's it going? What are you finding? And the guy would get back a 5-page email that has every single little detail in it. And he really just wanted to know it's going along okay. So that need to explain the detail. Does that show up in girls with or I should say, is it evident in girls? It's a good
question, and I don't know that I have the expertise to answer that. I didn't see it in this, kind of the plural of what is it? My husband of anecdote is data. So I have a very limited, tool that I'm looking at. Although when I look at it across our population, and we have thousands of parents in our community, I do see the interest in girls, but oftentimes the interest in girls is going to have somewhat of a more social application or wanting to have a more social application. But I don't know about the detail. I do believe that what we're probably seeing evolutionarily is that some of what we're seeing in terms of neurological, what we're calling diagnoses or conditions now, are really evolutionarily allowing us to adapt to this changing environment we're creating. But that's a whole
one example that one woman gave in about her. She's in her probably 30s or 40s, diagnosed, I think, when she's in her early 30s, said that it wasn't evident. And yes, I followed the, TV show Friends like others did, but I could tell you who did what in every single episode, who the guests were in every single episode for 3 years in a row. That level of detail where, okay, you watch Friends, and you talk about whatever happened. But she could go through all of those, or maybe boys, though I'm sure girls can do it with some sports, is knowing all the players, the statistics, 10 teams, who was traded, what this is going to implications, just that depth of knowledge that unless you asked, well, about, I'd say football, because my son's into football, and so am I, but the real football, not American football, soccer, and following, Premier League, but also the Liga and the Bundesliga, and 3 other leagues, and knowing details of players and style of play and everything else. That's a different level of detail.
Yeah. Yeah, it is. And it's easy to mask. And that's part of what we see with girls. Mm-hmm. They mask better than boys because girls have been trained socially, whether they're assigned female at birth or continue to see themselves as, to identify as female, they've been conditioned and trained to be pleasers, to be societally appropriate, to be respectful, to be polite. There's a lot of what happens in girls' conditioning, which is actually probably supportive and helpful for girls on the spectrum, but also teaches them, some might argue, teaches them to mask and to be less connected to themselves. And that's, it's a whole other conversation about the benefit or not of masking.
And I'd wonder whether, and I want to explore this more at future podcasts, also, whether you talked about the self-blame, whether then that turns into shame, because I'm not living up to this quiet, behaved, be socially appropriate. I can't do that. I should. And anytime I heard someone say should, I would think, okay, you got some shame going on there.
Yeah.
And
well, should is about expectations, right? And
if it's about expectations you're not meeting, but you're supposed to because you're being a good girl, whatever.
Exactly.
And I think kids in age 3, 4, 5, 6 take on, I'm not doing it, therefore I'm a bad person, rather than my behavior isn't appropriate. It's I'm not inside. And that's where the shame part comes in.
And I agree completely. And I think I see it in both ADHD and autism, that there's this what I call the blame and shame cycle that happens. And a big part of supporting adults with these issues, especially when they're diagnosed as adults, is first beginning to kind of ferret out and eradicate that shame and blame cycle and to shed some light on it. Because until you can bring people to some level of self-acceptance, you can't really move them through to a process of problem solving because they're going to be stuck in that blame and shame cycle. But I think shame has so much to do with how difficult it is to manage a lot of these issues. I am too ashamed and embarrassed to fill in the blank, to ask for help, to do it differently, to admit that I did it wrong, to try it again because I'm afraid I won't get there. There's a lot of ways it shows that.
And I think it's maybe part of ADHD as well as autism. And a number of people have both, but the perfectionism. And I see that more in girls, high school, middle school, but certainly high school. They are bound and determined they're going to finish the homework. And if they get everything exactly right, then they can't be criticized.
Yeah.
And so they end up sleep deprived.
Conversely, and my daughter said to me, and I'll never forget it, "Don't you see, Mom, if I haven't done it, I haven't done it wrong." So you've got that other side of perfectionism that shows up as actually what we would look at as, well, they don't care. Well, it's not that they don't care. Yeah. Actually. It's
maybe I've not picked up that so much, but the stay up till 1 o'clock.
Yep.
And then have to get up at 5:30 or 6. And high achievers and drive themselves. And of course, they have good grades. So, you don't have problems.
Reinforced.
You've got great grades. And boys give up at 7:30 and go play video games. So the grades are down. Oh, what's going on? And that gets investigated. And of course, that's a big generalization. But the trend, my experience has been girls are perfectionists. Some boys are.
I guess what I'm saying is that I think that there's more perfectionism than we realize, that perfectionism can manifest as high achievement. It can also manifest as extremely low achievement.
escape. Escape failure by not doing it.
Yeah. It was one of the most telling things they ever said to me, and I remember it now almost 15 years later.
So what's the approach to helping people with, and girls with Asperger's, autism, high functioning, and how does it differ if they don't have ADHD, or do you see more people that have both?
I was going to say, I don't know that I can speak to how it's different if they don't have ADHD, because there's a high correlation between ASD and ADHD.
Oh, yeah.
Like extremely high, way higher than we ever expected. One of the things that jumps out at me that I began to notice in this is not just what are we seeing in the kids, but what are we seeing in the parents? So the other warning signs I would look for are like, what are we looking for in the parent's experience, and how do we use that as a sign to help us support the kid? Because what we know about treatment for these kids, whether it's ADHD or ASD, is that a part of the treatment, one of the first lines of treatment, is to support the parent, to give the parent skills, support, understanding, so that they can understand what they're dealing with, so they can help their kid learn to manage it.
And talk about energy drain,
right?
The amount of energy. And parents just put in an incredible amount of time and energy, and then they're wiped out, and it strains their relationship.
Yes.
Whichever parent is kind of the support parent.
Right. Well, again, in my round, what I'm seeing is the parent who becomes the codependent, right, is drained. When I started looking at the families, what they all had in common, they all had histories of mental health differences in their families. Several of them had siblings who had not ended up functioning successfully as adults. Again, they sought support at really early ages for their kids, and they've typically seen multiple providers and maybe tried lots of different approaches that weren't as effective as they needed to be. Universally, these parents are kind of on the edge. They're like ready. They're just at the edge of their own breakdown or burnout. They know that something's missing. They're seeking clarity. They have begun to tolerate extremely disrespectful behaviors. They've reached the point of setting little or no limits or expectations for their kid. And they can't get any break because the child is obsessively attached. So the parents are reaching an end point.
And a parent, one or both, can have ADHD also.
Yes.
Or also be
or anxiety or OCD or
Yeah, there's certainly going to be anxiety there, but ADHD, okay, they aren't organized and they have a hard time sticking with routines, and they're parenting a child who does best if everything's routine and isn't a surprise. And because it's more anxiety if it's a surprise. So that's a tough blend.
That's this other factor that's happening. And I think an indicator for providers is if you've got a parent that's at their wit's end, it may be just that the parent has ADHD. And I say just, but that the parent is undiagnosed and untreated. That's for sure possible. But it may be that there is enough complexity happening there that hasn't been identified and supported, that the parent needs more. And what I found with all of these parents is that being in a space in our community and with me normalizing what was normal for atypical kids, and then beginning to be able to call out what wasn't, to say, that really does suggest that there's something else going on. That does invite me to say, let's do a reevaluation. That was really affirming for them, to have somebody else who understands complex issues to be able to say, no, this needs some attention. And many times it's the first time that any provider has ever said to them, no, I'm listening to you. I hear you. because there's this way when you've gone from provider to provider to provider, they kind of make us parents feel like we're the neurotic one with some, we just need to chill out. But you don't know what it's like when your kid's having these eruptions and explosions, and
from
blowing their bedroom
provider side,
havoc.
Yeah, the and I think one of the problems in primary care and our whole medical care non-system is the time that a primary care provider has to spend is, okay, usually it's to get 15-minute appointments. Yeah. And to say, okay, come back and see me next week. Well, next week is 5 weeks from now because your schedule's full. So there isn't the continuity. And maybe, okay, you come back, but someone else is covering, and the provider may reach the point of saying, I really don't know what's going on. Or say worse, say, well, it's just this. If you were better parents, it would work. Or there's obviously, you need these 3 medicines for your anxiety and whatever, and that should do it. So parents know, well, no, it's not going to do it. It hasn't before. They go see another one. So that's exactly where there's this bouncing around.
Well, and then the other thing is, so there's not enough time. The parent wants to maximize the time they have, so they're not telling the provider what their experience is because they don't think it's relevant. Mm-hmm. Mm-hmm. And so they don't want to waste the time because they got to get to the solution for the kid. And so, they're embarrassed, and back to the shame cycle. So the parents are embarrassed, and they don't want to tell their provider that the kid's thrown everything out of their bedroom and broken everything in the living room. They don't want to tell them that because that's embarrassing. And that feels like what they're going to hear is, well, you're not a very good parent, are you?
Yeah, you aren't setting the right limits and boundaries. And so if you just did that, they would learn to do it differently. And that's, I think, the
and it's hard not to buy into that trope. Yeah. You've done everything the experts tell you to do and it's not working. And so part of the reason I do what I do is because I read all the books and I did everything the experts tell me to do, and it didn't work. And that's why I wrote the Essential Guide. It was like I wanted a parenting book for kids who weren't so typical. Because the parenting books that were written for neurotypical kids did not work for me and my kids.
Yeah.
And it just made me feel more shame and made me feel more worried about my kids. Mm-hmm. Yeah. It turns out my kids are pretty amazing. I just have to help them get through it.
Mm-hmm. One of the things that's always struck me as central to autism, anyone on the spectrum, is anxiety is such a huge, huge thing there.
Yeah, I agree.
And I mean, you can speculate, yes, it comes because you're going to have problems in a social situation, or I don't know how to act when I don't know what the routine is. So no, I don't want to all of a sudden we have to stop by the grocery store, but no, we usually go from school, we go right to home and I have a snack. And so that can be part of the anxiety, but that's such a strong part that sometimes it needs to be addressed separately.
Yeah.
And I'm not sure it's a co-occurring disorder so much as it's part of that. And yes, sometimes anxiety medication, some supplements help anxiety enough. Does the anxiety show up differently in girls than it does in boys?
In some ways, I think it does, in the attachment pieces. And I agree with you. I used to say, and this is going back maybe 10, 15 years, there's a representation of autism called PDA, demand avoidance, which I identified in one of my kids probably 13, 15 years ago. And it's a diagnosis that doesn't exist in the US, but it does in Europe and then Australia. And it's beginning to come to this country. We're seeing more about it. And it came out of autism research in England. And I remember when it first started, looking at it and having a conversation with my husband saying, I wonder if 20 years from now, we're going to figure out that autism and is an anxiety-based disorder. And and it wouldn't surprise me. I'm not saying it is or isn't. When you talk to a psychiatrist who understands the neurology of it way better than I do, they will say no. And I lead into their expertise because I don't know. But there is a correlation that is so strong that I just don't think you can deny. I mean, I was actually with a group of psychiatrists and neuropsychs the other day, last week, and I asked, have you ever seen autism without anxiety? And one of them said, yeah, I've seen it. It's not common, but I've seen it. But typically they go hand in hand because, and I always say, if you can't get yourself to do what the world expects you to do, and whether that's ADHD or autism, it's going to make you anxious. And over time,
because you're
it's going to make
supposed to be able to do that.
That's right.
Yeah. And that's the message you get. Well, you should be able to do that at your age.
But
why don't you?
With girls, I think there's more. The anxiety manifests itself more in an attachment or connection to the parent, to a parent, and less resistance or avoidance or isolation from. So boys are more likely to withdraw in, and girls are more likely to lean in and hold a mom's leg. That's a gross overgeneralization.
Yeah. And I think of boys their anxiety, they're more likely to go into the meltdown, the explosive. I don't know how to deal with it. And it's either the meltdown part or self-blame. And then, okay, I'm just going to shut that out of my world and not pay attention to it.
Yeah.
I hope that's no longer part of what I think. I've refused to let myself do that. So people they trap themselves in boxes because they have all these things they can't do because, no, that's too hard to deal with. Or I failed once, therefore I never want to do it again. Yep. Or I failed and it hurts so much.
Yes.
I don't know what to do with that hurt, and I don't want to feel that hurt anymore. So I won't do the thing that risks being hurt like that.
Yes. Beautiful.
And maybe
right on target.
That takes some time to have had enough experiences where that happens. So it may be someone in their 20s and 30s, and I'm not sure how to get at that in terms of, are the things you used to like to do that you don't allow yourself to do now. I'm not sure what question I would ask to get at that.
Well, I think that, you're right on target, which is it's a masking of pain. It's an avoidance of pain. One of the kids, when I was doing this presentation for AppSARD, one of the things one of these girls said, and she was young, she was like 9 years old, and she was hospitalized for a suicide attempt. And she said, I didn't really want to kill myself. I just wanted the pain to stop.
Yeah.
That was a 9-year-old. I just wanted the pain to stop. Right?
Yeah. Yeah.
So there is a way, and maybe because girls are invited to be with emotions differently than boys, maybe girls are able to express that or connect to it or communicate it sooner or differently than boys may be. But I think the experience is all the same. There's an experience of feeling pain in being in an environment and being surrounded by the expectations of environment and not knowing how to navigate that pain productively.
Yeah, and being somehow chastised or run afoul of usual societal expectations, whether it's with relationships, girl with boy, boy with girl, as far as cross the line because of what you'd seen your thought it would be how that hurt too much to be rejected. So I'm never going to do that again. And so, no, I don't go out with girls. I don't date.
And building a frustration tolerance is really hard for both ADHD and autism. Because when there's limited tolerance for frustration and mistake and disappointment, and then you add the common experience of having more frequent disappointment and mistake, at some point, the way to avoid it is to just not try.
Just not do it. Now, one of the things you mentioned, I think it may have been before we started on the recording, was helping providers, clinicians, know what to ask, what kinds of questions to ask, because this is now coming out and as far as becoming more evident that, this is a real issue, and there are kids and adults that something's not right. How does a clinician get at that, whether it's suspect something's not right, or a parent comes in and says, something's just missing here, could there be anything more?
I think that's a really important question. And that I think one of the things that's been missing in this dialogue, I don't mean ours, but generally is what do we need to be guiding providers to be looking for and asking? And so part of what I was trying to identify by saying, what do these very complex kids look like? What do the parents look like? So to really asking more questions about what the parents' experience is. But what I think parents need from providers is they need providers to be looking for these signs of very complex kids and looking and understanding that there may be a more nuanced diagnosis, particularly for kids who were initially diagnosed before 2013. Because in 2013, the DSM changed. Prior to 2013, a provider could not diagnose a child with both ADHD and autism. They had to choose.
Yep. If it's this, then it can't be that. Yeah,
so there's
absurd.
There's an entire generation that we need to be looking at. Anybody who was originally identified before 2013 is to look for some more nuance in diagnosis. Ask about questions about parenting challenges, and look for the
the parent's experience.
Right, look for those outliers. Set appropriate expectations for the parents. Let them know that there's not an easy fix, that they're not alone, that this is a long-term journey, and that they deserve support in this journey, that they shouldn't do this. Which means encourage parents to get behavior management training, which is part of recommended treatment for these kids, including teenagers. And I've had providers say to me, well, if it's really bad, I refer them to training. No, don't wait till it's really bad.
Right. That's the idea, is to prevent that really bad. And I think even something as simple as, see that you've been to, how many is it? 4 different people, and you're still something's wrong. You're great at persistence. You obviously really love and value your child. It's got to be very difficult to value a child who's throwing temper tantrums or doesn't want to have friends, doesn't want to go do anything with other families like your older son does. You're doing an amazing job keeping after, trying to come up with what's going on.
Yes. Slow down and acknowledge the parent, because the parent needs that acknowledgement a lot, like so much. And I think a lot of times in our community, what we hear from parents is, this is the first time I've ever felt like I'm not alone. It's the first time I've ever felt like I'm not crazy for having the experiences.
Someone's listening.
I mean, other people have this too. I had no idea.
Yeah.
And that if you can, even if you don't know what the experience is, to say you're not the only parent going through this. And when you get some support for yourself, it will help your kid. Explain to parents that they need more than information. They need support. because
some
the research shows us they need more than information, right? And then I think the last thing I would say to providers is stop worrying about offending parents and encourage them to get the training they need, because providers don't want to embarrass parents by suggesting parent training when in fact it's what they need the most.
Yeah, and what I've found, I mean, I'll read in some initial studies of such and such an approach, and there's been grant funding support, and they have a behavioral team at the clinic, etc. Well, there isn't a behavioral team in most primary care offices. Even in now 70% of primary care offices are owned by hospitals or other corporations. They may have psychologists in that network, but they aren't right there.
Yeah.
They can't say, let's go down the hall and get you lined up with, or they don't have the parenting. So I can say, a parenting program would be a great idea. How do you find it as a clinician?
That's where we come in. That's why we're virtual. And it's whether it's us or someplace else, it doesn't matter. But these parents need support. And if COVID taught us anything, it's that it doesn't have to be in person. For a long time, we had provider bias that says it has to be in person. We know, we've been doing this for a dozen years, that parents can get effective support virtually through a community of peers online. Just like we were talking about, kids can connect socially online. Parents can connect and get support virtually. And it's more affordable. It's more accessible. It works better in their lives.
Absolutely.
Yeah.
And someone in Seattle can work with you in Georgia. Yeah. And it works fine. As long as the technology supports us, that's the trick. But it is face-to-face, so you can read facial expressions. You can get this whole different dimension than trying to do it on telephone. And I think when technology wasn't there to be able to support the virtual stuff on the phone, you can't really work with it. And I think you're absolutely right. COVID has helped us see that, yes, it works doing it virtually. And, well, there's technological challenge. And I will say with technology, and maybe it's with much of life as well, it's knowing the workarounds. I've been doing virtual visits even before COVID, and we walked in one day and my record system, which coordinates virtual visits within it, you couldn't access that part of the system. It just wasn't there. And I had a whole morning of patients. I thought, can we do that on Zoom? So I always set up a Zoom meeting to go for 4 hours, so it's available if any patient can't connect, either our own technology issue or our whole system is dead. So
we got to get creative, and we live in a really creative world. So there are a lot of ways that we can get the training and the support and the coaching that we as parents need, if we're willing to ask for it, and if providers are willing to encourage it. Because the truth is that until a provider says this is part of your child's treatment, the parent actually, and we've done some research on this in our community, the parent tends to see parent training or parent intervention as a luxury. They see it as an indulgence for themselves. Why should I focus on me if my kid's the one with the problem? When in fact, we know that if you focus on you, you'll begin to learn how to help your kid navigate the challenge. But it seems counterintuitive to parents, and so they really need providers to be saying to them, it's part of your kid's treatment. Yes, this is recommended. But that they
put on your oxygen
only hear
mask
it about
before
30% of the time.
Yeah.
So it's unfortunate.
The analogy of put on your own oxygen mask before you put your child's on. You can help your child best if you're in good shape and taking care of yourself.
Well, and I might augment that by saying, put on your oxygen mask, and not only does it have oxygen, but it's got fuel and food and water and energy and everything in it to really boost you. It's not just survival. It's more than that.
And I can almost hear many parents almost, and where am I supposed to find the time to do that?
Right, I can't do it. Yeah, I know.
And I don't think there is any role in society at all that's more challenging than being a mother, a wife, and having a job. Right? You can't do all of them as well as you want to.
It's hard.
And so
here's what I will tell you.
Yes.
Here's what I will tell you is that I hear this from clients all the time. I didn't think I had the time. And what happened was that I ended up having more time. Because when you start to navigate
struggle,
these
there's
issues,
less energy drain.
There's less energy drain. And so you actually end up with more time, more space, more freedom. In our realm, there's a lot of emphasis on self, taking care of yourself as a parent. So all of a sudden parents are taking care of themselves. Somebody will be in a group and they'll come in 3 months later and it's like, this is the first time I've gotten a haircut in 3 years. And, it's like,
I was able to go do something else. Yeah.
And that's powerful because that's what it takes for us to go the distance. Because, we talk about it at Impact in terms of the marathon view. You're in this for the long haul. And if you're running a marathon, not that I'm a marathoner, but if I know that people who run marathons, you have to make sure you get water breaks. You have to keep getting nutrition. You have to, there are things you do to prepare for a marathon. You don't just get up and walk a marathon. And the same is true for parenting complex kids. This is a marathon and you got to pace yourself and you got to nourish yourself and take care of yourself in the process.
Well, I think we need to break. I'm sure we could keep talking for another hour or more. There are all kinds of nuances and things that are there. But the kind of takeaways that I see is for a clinician to support parents who come in and they're at their wits' end. They've seen 3 other people. And also to believe parents who say there's something else that's just not right. They've treated the ADHD appropriately. They're getting appropriate help with learning disability, but something doesn't fit. Parents know their children a lot better than you do, doctor. Believe that they know something about them. And I think to let parents know you aren't the only one, that there is help, and getting support for yourself is one of the best ways you can support your child.
Yeah, for sure.
That's helpful. Well, my guest today has been Elaine Taylor-Klaus, founder of Impact Parents and author of one of the better books on parenting, complex child or not, The Essential Guide to Parenting Complex Kids. And every child's complex, and many of them are more complex and more challenging for parents and people supporting them. So thanks for listening. This is Dr. David Pomeroy on ADHD Focus, and I hope you'll join us again for another time.